Hi, welcome to CT Guided Biopsy at ctbiopsy.com. This is Dr. Bhavin Jankaria, and here we have a 149th case, an upper buccal space biopsy using a paramaxillary approach. Now, the level of difficulty would be 2 by 5 or 3 by 5, depending on your expertise and experience, but really not more than that. So this 54-year-old had been treated for an upper buccal squamous cell carcinoma, had pain and difficulty in opening the mouth. This was the soft tissue that was seen during the PET-CT, and it was reported indeterminate. So 6 weeks later, a contrast CT was done, which showed the soft tissue unchanged, little increase anteriorly, and the decision that the oncologist took was that we should get tissue for a biopsy. And since it wasn't accessible per oral, the patient was referred for a CT-guided biopsy. And we have to run through this entire pre-procedural checklist, review the notes, see if everything is fine, check the route in advance, and this is the only route available anyway. And it's simple and straightforward, no vessel coming in the way. The pterygoid plate acts as the posterior rate limiting structure because the bevel will eventually hit it, but there's enough play here to do the biopsy. So a patient had a normal coagulation profile. We knew that the biopsy was really to differentiate between fibrosis and tumor recurrence. At the time of the procedure, went through the entire checklist and everything was under control. I used an 18 gauge short, Cook gun, 10 millimeter throw. That's the entry, and then went in a little bit, withdrew a little bit, and then basically deployed the gun and did the biopsy. The post-procedure course was uneventful. The working diagnosis was fibrosis versus tumor recurrence. At the time of the biopsy, the lesion was hard and gritty, so I thought maybe this would just turn out to be fibrosis, but there were tumor cells within the fibrosis, so this was local recurrence of squamous cell carcinoma. To run through the summary, it took 8 minutes. We used a paramaxillary transbuccal approach. Level of difficulty will be 3 by 5 or 2 by 5. And that pretty much is it. So I keep adding to this. I've been building this up over the last 3 years as I keep adding cases, and except for transoral, which I do not do because you need general anesthesia for that. We've looked at all the various routes that you can use for suprahyoid lesion biopsies. This was the intramaxillary sinus lesion that I looked at in case 113. Then this was a retroorbital mass that I biopsied using a subzygomatic approach. Another subzygomatic approach in a recurrent adenoid cystic carcinoma. Then you have a suprazygomatic approach for a nasopharyngeal mass, but a nasopharyngeal mass can also, you can also get there using the paramaxillary approaches. So this was the lateral retropharyngeal node, and this is another parapharyngeal mass. All of these are paramaxillary approaches. Then you can also get to the nasopharynx in this way. So this is again in a way a kind of a subzygomatic but a supramandibular or a transmandibular notch approach. This was a retromandibular or a retroramus approach for a parotid lesion, which turned out to be oncocytoma. And this was a prone. I don't really use prone for suprahyoid unless you're looking at spine lesions, but I don't include them in this when we're talking about suprahyoid neck biopsy lesions, right? And this was a perimastoid where there was abnormal soft tissue here, and this turned out to be aspergillus. So just to summarize, suprahyoid approaches are usually simple and straightforward. As long as you understand the anatomy, you do need a good contrast CT or MR in advance, but that's pretty much it. And then buccal space biopsies are even simpler. You can run through the entire list here in the table of contents. That's my link tree to all the posts. And I did the Atmospheres post this weekend where I talked about why we focus too much on being on the whole obesity overweight thing when the differential issues of being overweight are actually quite minimal. It's just more important to be well fed than not have food to eat. That's the book. That's my lecture that I put up at CT Chest Review, another lecture at BST Neoplasms, and that was my last week's case for cardiac at the cardiac MRI site or mricardiac.com. You know where to email, subscribe, etc., comment, and have a great week.